go over some things today and just answer some questions about outpatient CDI and some things that we have learned doing that as well. All right, so I'm going to get started here. And first off, today, I just want to identify some of the benefits of an outpatient CDI program, and identify some of the various outpatient initiatives, and also how to improve upon an existing outpatient CDI program. And just to give a little bit of background, as Chris had said, I was with an organization who started an outpatient CDI program back in 2014 when it was still very new, and it was a program based upon a Medicare Advantage plan with the organization that I was currently at. And the outpatient program is currently going under a revitalization process with some implementation of new software. And I'm just going to kind of go through some of all that as we go through this presentation. But I started out as why is outpatient CDI important? Because I think just having that background of knowing why to even consider an outpatient CDI program is important as well. And as we all know, as healthcare costs continue to rise, it's very important for that clinical documentation and coding to really reflect everything that we are utilizing for the patient, all those resources, how sick these patients are, having that accurate acuity. And then when each diagnosis is being captured to that highest acuity and that specificity, it will show, again, how many resources that would be needed to provide and care for that patient. And we always tell our providers, you're giving those great patient care, you're trying to do what's best for your patient. And so you want to make sure that your documentation is reflecting that great care and all of those resources that we are using in order to provide those things for our patients. And if all the codes are captured correctly, the patient's story can be told. And we want to make sure it is an accurate story and making sure we know, okay, this is where maybe a patient's been here for a while, we know where the patient started at, and also where this patient is now. And it can change from year to year. So that's why, again, it's important each year to make sure that we're capturing all of those diagnoses and making sure we're giving that patient story each and every calendar year. And chronic illnesses and conditions can utilize many of the resources and should be accurately reflected. Because if you have a patient who has a lot of comorbid conditions, we may be, sending them to different specialties. They may be requiring all kinds of different resources for medications or testing, things like that. Your CKD patients, they may be, on dialysis, things like that. So you just want to make sure, that all of those resources that are being used to take care of that patient's reflected. And then the accurate code capture can also help healthcare facilities make budgeting decisions, because if we are using a lot of those different resources, then if the healthcare has a heads up, okay, this is how much is budgeted for these patients, it gives an idea about those different things. And so if you are thinking about doing an outpatient CDI program, is some of the things to ask as well. You want to really identify what's important for your facility, because your facility may be different than others. A emergency department program may be what's important at your organization. Maybe you're focused on outpatient areas. You maybe want to just do internal medicine or family medicine practices. Also, if there's a certain specialty. So for instance, maybe if there is like some cardiologists that really want to focus in on how they can do well into their documentation. And so getting started may be even as simple as focusing just on that specialty to see does it really make a difference with having that documentation improvement, those codes, things like that. And then also looking into what type of electronic healthcare system you have. Do you have the records that are easily accessible to make sure that you can review all of those patient encounters? Things like if you have Epic, you can go in and look at all of those past visits within the past 18 months to 2 years to pull forward any of those diagnoses that have been documented or coded in the past. Do you have software that is capable of showing like the risk adjustment scores or the gaps, and which I'm going to go into more of these as we go on. But these are, again, just some questions to ask about your organization even. And what staff do you have available? Do you have people that have experience in outpatient CDI? Or are you thinking of training your inpatient CDI for a pilot, or either getting them to come on board for the outpatient CDI program? And so here again are some more benefits of an outpatient CDI program, because as we all know, you can improve, the documentation follows improved quality metrics. MIPS is another one with a merit-based incentive payment system, your hospital quality reporting, your agency for healthcare research and quality, all those indicators and more for your quality metrics. Also, you can improve your charge capture, generating itemized statements, tracking data, monitoring the cost of patient care, furnish cost data to financial systems, and then risk adjustment factors to predict future costs for a beneficiary. So these are just all some things to consider. And again, whatever may be important for your organization. And I'm going to talk more about the risk adjustment factors, as that's the one that we had at the organization I was at for outpatient. We focused more on those risk adjustment factors. And then also, before we move into that, I wanted to bring up about the 21st Century Cures Act, and that's also it's something to think about with the outpatient CDI program, because the Cures Act, was designed to help accelerate, the medical products and bring new innovations and advancements to patients who need them faster. And also, with the Cures Act is making sure that the patient is going to be able to see their health history. And if you have electronic medical charts, things like that, they're going to be able to see everything that the provider is documenting and coding on their chart. So as providers, you really want to make sure that you are capturing all of those diagnoses accurately, and it's reflecting what that patient story. And you'll see here some of those key components, additional diagnosis codes related to mental health and substance use disorders are some of the things that are on for the CMS to make improvements with. The severity of chronic kidney disease, taking into account that the Medicare Advantage enrolled individuals' total number of diseases and conditions by making additional adjustments as the individual's number of diseases or conditions increase. And then also there's going to be phases and changes of risk adjustment payment over a 3-year period, which began in 2019 and then will be fully implemented in 2020. So there's just, over that 3-year period, they're just adding, those key components. And then for 2020, CMS also will use the alternative payment condition count, which is like a blended risk score calculation. You'll have like even additional HCCs for dementia and stage 2 pressure ulcers. And then here are some of those factors and coefficients that will figure into the beneficiary's total risk score for 2020. So you have the age, sex, the Medicare and disability, HCC, disease coefficients, any other disease interactions, disabilities, and then also you have some of those payment HCC counts for these coefficients. But this is just some of those, I thought was just good information to include in there, and just making sure that our providers, are documenting, accurately to reflect actually what's going on with those patients, and especially since the patients will be able to see those the progress notes and those visits and things like that. And so the HCC models, there are different ones. And then again, the CMS HCC model is the one that I am most familiar with at the organization that I was at. But there's also the HHS HCC models, your RX HCC models, and your CDPS. And we also focus on those RX HCC at the organization to make sure that, this Medicare Part D and managed care plans, to make sure to capture all the diagnoses that may not be covered in an HCC category, because those CMS HCCs was developed by CMS. It's based on those yearly face-to-face encounters, so they must be seen by a provider at the time, and that provider must document and code that diagnosis at that face-to-face visit. It can't be another note entered without being seen at a face-to-face encounter. And it's the Medicare Advantage plans for age 65 and older, or the disabled that are less than 65. And then there's versions for new enrollees, community, institutionalized beneficiaries, and then end-stage renal disease. So there's some of those different versions within that CMS HCC model. And then HCCs are excluded diagnoses that are definitively treated. Like, say, if it's acute appendicitis, that's not considered an HCC. And then if it's clinically insignificant and non-diagnostic. So those acute conditions are not usually labeled as those HCCs, because it's that hierarchical care chronic condition that you're really making sure you're capturing those chronic conditions each and every calendar year. And so for the CMS HCC classification system, here are some of the principles for that. The diagnosis must be well specified and clinically significant. Diagnostic categories must help predict the medical cost. Adequate sample size of patients should be reviewed for cost. Hierarchies are used to help establish the patient's illness level. Specific diagnostic coding is necessary. Each disease is only counted once, and that is within the HCC category. So for instance, if you have other HCCs, they will be counted as different categories. But if it's, say, diabetes, and you have diabetes with CKD and diabetes with neuropathy, it will still only get counted once within that diabetic HCC category. That's what that means for that. The providers are not penalized for recording additional diagnoses. So that's the same, like you can still code and still document any of those additional ones, but it would just only be captured within that one HCC category if it falls under the same one. Consistency of the medical record. All applicable codes are reported. Diagnoses not clinically important or credible as cost predictors are not used. Again, some of those acute examples that was on the previous slide about the acute appendicitis and those other insignificant diagnoses, even though they are significant at the time of the visit, but that does not count as one of those HCC classification. And so for risk adjustment, again, the risk adjustment methodologies combine demographic information and documented disease and conditions, and also information that's used to predict the cost in the following year within this CMS HCC, the hierarchical condition category model, because it's, again, each calendar year is when that is for January 1st to December 31st. And then the individual patient risk adjustment factors are recalculated each and every year. So the HCC codes must be reported at least once in the preceding year on a claim related to the face-to-face provider encounter. So even if it was documented on December 31st of 2020 and the patient was seen on January the 1st in a new encounter, it needs to, everything starts over January the 1st. So within that calendar year for now for 2021 that needs to be captured and coded for that patient to be for this calendar year and at a face-to-face encounter. The higher the risk adjustment score, the more complicated or compromised the patient is. HCCs are assigned using hospital and physician diagnoses from hospital and patient diagnosis, outpatient setting, physician, and APP documentation. So it must be documented and coded by a provider who is seeing that patient in a face-to-face encounter. And it can't be like a telephone visit or anything like that. Again, it must be seen at those face-to-face encounters. And so here is just that, again, with that risk adjustment. If you have a low risk adjustment score, that may indicate a healthier population, inadequate chart documentation, incomplete or inaccurate ICD-10 coding, or patients who are not seen. Because when you have that lower score, it looks like, oh, well, these patients are not very sick. So, that's not going to take much of the resources and as much to take care for them each year. But if you have a high RAF score, it may indicate members with increased health risk, reported diagnoses without supporting documentation, overcoding, coding based on documentation that was copied and pasted from the problem list to assessment plan. So that's really important as well. So we don't want to inaccurately show those scores. So if there is a low RAF score, and that patient may be a very healthy patient that doesn't require much resources. But when you do have those higher RAF scores, you want to make sure that you are reporting those diagnoses with supporting documentation. And I'll go through that a little bit in the next slides, where you're meeting the criteria. Was that diagnosis monitored, evaluated, assessed, or treated? So that needs to be in the chart in order to make sure that that is a valid diagnosis. And then even with that overcoding in the problem list or an assessment plan, as we all have heard, the problem with the problem list, sometimes those things never really get deleted. And so it may get captured and keeps rolling over year after year. And it could be something that is no longer viable for that patient, or maybe it got put on that patient's chart and it's not really a viable diagnosis for them. So just making sure that all of that is very accurately reflected. So when we do have those the members with increased health risk, you really want to make sure it's supported and not only just that code. Because if you just put that code in there and there's no treatment, there's nothing monitored, so then that's when that overcoding could be a problem if it's not supported in some way. And so going in for that documentation of the HCCs, your average risk adjustment factor score is 1.0. Anything above 1.0 represents a sicker, more complex patient. The higher the RAF score, it helps support the resources and costs used to care for the patient. And providers must document every diagnosis to the highest specificity and acuity to reflect accurate severity of illness. Documentation must support the presence of the condition with that monitoring, evaluation, assessment, and or treatment of the condition, because you really want to stay away from unspecified codes, because incorrect or non-specific diagnoses can affect not only the patient care and outcomes, but also the future reimbursement for the care that the patient's receiving. So if you are doing those unspecified codes, sometimes it does not get coded to an HCC or has a lower score. And so the physician may be coding that that condition is there, but if it's an unspecified condition, it's not really being accurately reflected to what is really going on with that patient. And I'm going to give some examples too, especially with the major depressive disorder and things like that. And so again, with the documentation, CMS uses those HCC risk adjustment models. And you want to make sure that you identify a list of the diagnoses and conditions that have statistically demonstrated increased cost and group them into those HCC categories. So when I refer to the categories, it's broken down. So for you have, especially say for your diabetic patients, and then it'll have your categories of just your regular E11.9, the unspecified diabetes. And then you have your diabetic patients with complications or with acute complications. All of those are within that category. And so they are grouped because they are all demonstrating similar cost patterns. They're all within that HCC grouping or category. And HCCs are given a numerical weight or relative value that can be added together to compute an individual's risk score. So as again, like here you'll see HCC category 17 is diabetes with acute complications, and that's which will give you your highest risk score. And then your HCC category 18, which is your diabetes with chronic complications, that's just your average risk score, but it is higher than the HCC category 19, which is the diabetes without complications. And so that gives you your lowest risk score, and that's that E11.9 code for like type 2 diabetes unspecified. So that one gives you your lowest risk score, and then as you get with your chronic complications or your acute complications, that gives you a higher score. And so this is just a table to kind of show how that really does affect your risk adjustment score. So this one here, the 2019 risk adjustment factor, you'll see the total RAF score was 2.462 because they got diabetes or retinopathy is documented and coded. You have morbid obesity documented and coded. Rheumatoid arthritis is documented and coded. You got dilated cardiomyopathy, you got COPD, and then they have some of that CHF and COPD, diabetes and CHF interaction score just added to that. And so that's how they came up with that 2.462, which is well above that average 1.0 risk score. And then, so this patient come in for 2020, and for the risk scores here, they've only got the diabetes, retinopathy, and the morbid obesity. They didn't capture the rheumatoid arthritis or the cardiomyopathy, the COPD, or any of those other things. And so then you get a RAS score of 1.43. So that is a whole point less than what it was before. And then when you're taking this calculation that they do based on those RAF scores, you had, well, the missing is, I'm sorry, 1.431, and then the total RAF score was the 1.031. And so when you do that, basically, the per month is like $799. That's all that they would be getting. But if you add all of those, and then you have that score to at least what it was even last year, it was 2.462, and it's $1,810. And so, that's that, over $12,000 annual. So it makes a huge difference, just making sure that you're capturing those diagnoses to the highest specificity, to the ones that will, give you a higher risk adjustment score if it's appropriate for that patient. And so, but that's just kind of showing you those numerical dollars as well that gets, is affected by those risk adjustment scores. And then even things for like obesity, I just put a little table here. If you have your morbid obesity, and then even your morbid obesity with the alveolar hyperventilation, that gets into that HCC category 22. And so as you have up here, and you'll see that those scores has a higher RAF score, which if you just document overweight or other obesity or just obesity unspecified, that is not a HCC and does not get any of those risk adjustment scores. So it would not be reflected in that. Also, capturing when you do the obesity, capturing the BMI as well is very important, because if you do the BMI, that also goes under that HCC 22 category, and affects your risk adjustment score. And then if the BMI is between 39 and anything below 40, as you see here, is not considered an HCC. But if it's 40 and above, it is considered an HCC. So whenever they are documenting that, it's very important just to make sure to include those BMIs as well. And you mentioned, and I heard you when I was mentioning the documentation requirements, you have to have that meet criteria. You monitoring the diagnosis, if it's observation, and monitoring signs, symptoms, the disease, evaluating, reviewing the diagnostics, your medications, treatment, assessment, if you're doing a physical exam, labs, x-rays, discussion with the patient, treatment, again, the medications, therapies, things like that. So anything when there's a diagnosis that is appropriate for the patient, the provider should have some of that criteria, even if it's just diabetes, continue metformin, monitor A1C at next visit and follow-up, things like that, just making sure that they had addressed the diagnosis and they were monitoring it and treating it. And so they have met that documentation requirement once they have made to do those different documentation. And then documentation should be accurate, clear, and concise. History and status codes should also be captured if it's impactful to the patient's health status. Things like a history of MI, trait status, colostomy status, even long-term use of insulin, because some of those trait status, colostomy status, insulin use are also considered HCCs with that. And then documentation must clearly link any of the conditions that are due to or other diseases. So like diabetes, you can't assume any of those manifestations. So the provider must clearly link that. So they always should be, diabetes with CKD or diabetes with neuropathy. Because I know at the inpatient side, it can be assumed for some of those, but within the outpatient side, it must be clearly documented by the provider. And then this is some of the documentation examples. So for inadequate documentation, if the provider just put patient with CKD presenting for dialysis, and so really it would only have that N18.9 and Z99.2. That's all that would be coded for them. But if they put in their documentation, patient with CKD stage 5 and hypertension presenting for dialysis, then that would go to that combo code, that I12.0 and the N18.6 and the Z99.2. So then that can be captured to a higher specificity. And it would also, because N18.9, it's just that unspecified code, it'll specify that CKD. And then also like an inadequate documentation as far as atherosclerosis of the lower extremity, and then bilateral, and then hypertension. So if they were to document atherosclerosis of lower extremity with intermittent claudication, bilateral, and then hypertensive heart disease with heart failure on medication, that also gets you those more specified codes. And your depression, so if you just put depression, patient on medication, it goes to the unspecified code. But if they were to document depressive disorder, single episode, mild due to problems at work, meds given, referred to counselor, then that would give you that more accurate code. And also it makes it to where it has that meet criteria. And then if it has just type 2 diabetes without complications, and then they also have documented cellulitis of right lower limb, that just gives you that unspecified diabetic code with the cellulitis code. But if they had made it to where it was like a chronic foot ulcer and it has exposed fat layer of the right foot, because maybe that is what was really the problem with that, it gives you that more specified diabetic code also with that ulcer code. So just making sure that the documentation really reflects the accurate patient picture, because just documenting the basics, that captures, that's good. But if you can improve your documentation to really to what you're treating or what's really going on with the patient, it tells that patient story. And then this is a query example when we were doing the outpatient CDI. This is just an example for like a depression one. So on 2/1/20 office visit, depression unspecified, F32.9 was documented and coded. Medications include Zoloft, last refilled 1/3/2/21. If appropriate and depression remains viable, please provide diagnosis with code, assessment, and treatment and upcoming visit documentation. And so then there's some code choices there to see to help you further specify that depression. And here is what an adequate documentation example would be. So if the doctor would actually put major depressive disorder, recurrent, mild, continue medication, and counselor referral, will follow up at next visit. And then that code F33.0 would be captured. And then also that meet criteria is met if they have that answered in the documentation. And I included this for the major depressive disorder codes because some of them that are CCs and HCCs, just making sure that they document that mild, moderate, severe, or if it's recurrent or not, that really helps drive those HCCs and also FCC in inpatient world. But the codes that are not CC or HCC is that F32.9, the unspecified depression code. The single episode in partial or full remission, other depressive episodes, or recurrent depression that's in partial or full remission. So I just put this here as a reference to see, just how important it really is just to even say, if it's a single episode, recurrent, mild, and moderate. So that's just some of those examples, or what's a HCC or not an HCC. And here's just another example here. On office visit 3/5/2020, type 2 diabetes, E11.9 was documented and coded. Numbness and tingling in the lower extremities was documented in the physical exam. Medications include Neurontin and metformin, last refilled 2/21/21. If appropriate, please provide any manifestations or complications related to diabetes with code, assessment, and treatment, and upcoming documentation. And so then the doctor had previously just did the diabetes, but in the physical exam, he was saying the numbness and tingling, and then the medications included Neurontin. And so we give the code choices with that diabetic polyneuropathy, or then if it's still just diabetes without complications. And if the doctor answered, this would be adequate documentation. Type 2 diabetes with polyneuropathy, continue metformin, Neurontin. Diabetic foot exam normal, check A1C today, and we'll follow up with the patient about results. And then you would get to that code E11.42, and also it meets that criteria as well. And I didn't put any of those codes for the diabetes because there's just so many, but having that specificity with a diabetes is very important. And I know I had, when we had started our program back in 2014, some of the staff that we had worked with, they actually, one of our contractors was a part of a team that just did diabetic patients, even just to capture those patients, just to get those manifestations, captured and coded accurately. So, and that continued to be one of the ones we would send the most queries on for just getting that diabetes manifestations or complications added, because if you've seen previously on those other slides, it does make a huge difference making those risk adjustment scores and those RAF total scores there. And so now that I have gone over kind of outpatient CDI, why, and a little bit of the background, now I'm going to go into more of that Revitalizing the outpatient CDI program. So the original program at the organization that I was at, we had a team of 4 contractor outpatient CDI and a team lead. We had a manual process when we first started. There was no software. We utilized Epic, Access tool, a Word document, Excel spreadsheets. So it was manual and a lot of back and forth between different applications. And the organization had a Medicare Advantage program at the time. And so we were able to see those gaps in cares and the risk adjustment scores for our own Medicare Advantage program. And so those gaps mean whatever was documented and encoded previously needed to be captured this calendar year, or basically noted that it was no longer a viable diagnosis. So that's what I mean by those gaps in care. And then when we were with that Medicare Advantage program, they were able to run the scores and say, okay, these are the patients that need to be seen. These are the ones that have a higher risk adjustment that is, when I gave you that example before for the prior year that needs to be captured. So we were able to do that. But then the Medicare Advantage program ended. And so after that ended, then we started to go into just looking at our Medicare Advantage patient care population for things for, like Humana, United Healthcare, and Aetna, and those Medicare Advantage programs. And we would look only at the physical exams, and it was all pre-visit reviews. So that was kind of our original program. And because it was such a manual process and no software, things like that, we would review between 10 and 12 charts a day. And with those 10 and 12 charts that we review, we would look back about 18 months to 2 years to see, okay, what was previously documented and coded that needs to be brought forward to this calendar year. So we will look at those encounters and look to see how we could bring those forward, but also looking at the medications, looking at all the diagnostics. Is there anything else that we are missing that's being treated or monitored or evaluated that we can also bring forward? So we would also do a comprehensive chart review in order to do that. And when we would see opportunities, we would send a query in the Epic and basket prior to the face-to-face visit. So that way we have all our clinical indicators, and then the queries that we formulated would be sent to that provider prior to the visit. So that way the physician could review that and address that at that face-to-face visit so it could be captured. And then that review was done on a Word document tool, and then we would paste into the Access tool. And so that Access tool would be where we would run reports. And what we could do, we didn't really have those risk adjustments for each of those. So what we would look at as the number of HCC queries that were answered, that response rate. And then also we looked at the RX HCCs. So we would keep a report on how many of those were answered and look at those response rates, because our reconciliation piece was once after the patient was seen at that face-to-face visit, we would go back into that chart at that encounter to see, did the physician actually document and code that query answer that we had, or did it just, they didn't answer it at all, or maybe he said it was no longer viable. So that's where we would go in and do our reconciliation process to see if it was captured or not. And then also we look to see if that meet criteria was there. If it wasn't there, we would put that on our reports as well. So that way we could provide education to the providers about some of the things that may have been missing, or some of the top queried diagnoses, things like that. And then during COVID-19, the census dropped in spring of 2020, and then inpatient CDI was trained to do some of those outpatient CDI cases. And then after the outpatient CDI had been put on hold during the fall of 2020, and also because it has been going to be revitalized because a new software implementation that will be coming into play for this year. So that's why it's into that revitalization stage, because we had that original program that was such a manual process, but now we're going to be moving to a software-based program. And so these are just some questions too, like why implement a new outpatient CDI program? Recognizing areas of opportunity within the Medicare Advantage payers, because there could be some incentives for documenting and closing the gaps in care each year. Things, with Humana or United Healthcare, if you go in and make sure the providers are addressing those diagnoses each year, there could be incentives for the program, for the organization. Also, increasing your risk adjustment scores to make sure you're accurately reflecting the acuity of your patient population. Also, if you're a part of an ACO, it can support those initiatives for that. Capturing all diagnoses accurately for overall quality of care and utilization of your resources. And also, there's now more software that's available to see those gaps in cares and those RAF scores to be able to recognize those areas of opportunity, because it's come a long way since our original program. And again, this is just some benefits of the documented HCCs. Like I had said before, those Medicare Advantage program incentives. You may get those from some of those healthcare plans. Also, MIPS. Again, that merit-based incentive payment system. They will determine Medicare payment adjustments using composite performance score. Eligible clinicians may receive payment bonuses and payment penalties or no payment at all. And then, as you know, the quality, the MIPS also replaced that PQRS and requires eligible clinicians to report data to CMS for quality measures related to patient outcomes, appropriate use of medical resources, patient safety, efficiency, patient experience, and care coordination. So if you're accurately documenting and capturing all of those diagnoses and having those documented criteria, you're able to meet those MIPS as well. And then also, again, the accountable care organization, making sure you are, just all that, having that specified documentation and follow through, and that follow-up can also help support some of those initiatives. And so with the program in the works, there's going to be, the 3MM modal, some HCC collaborate. And so right now it's all still in a learning phase. And this is just some examples of the patient population. Everything is still things to really consider. Maybe the Medicare Advantage patients for United Healthcare, maybe looking at them to see what gaps are missing and what incentives are offered to close the gaps. If you're going to maybe look at all Advantage, Medicare Advantage patients, have the CDI specialists review prior to face-to-face visits, looking at the diagnoses to bring forward and to see if there's any other diagnoses that can be further specified for the upcoming visit. And then also there's the retrospective piece that you can look at to see that what wasn't captured at the face-to-face visit. Also, maybe looking at your Medicare patients, doing the same type of workflow, or even if it's the emergency department, looking to see if that is something that your facility needs. And so this here is just the vision for outpatient CDI. And so if you have that software that's able to give you those risk adjustment scores or those missing gaps, you can utilize that software to identify your most important patients. Okay, maybe have them come in for a visit so that we can address these issues and make sure and not only just to address it for even for payment issues, but also the quality of the patient care. Like if those patients have all those chronic conditions, we want to make sure that we're providing good patient care and that we're following up the patient. So it's all about the patient satisfaction, and it should be all about the patient anyway with the outpatient CDI program, not just about incentives, but also just that overall quality patient care. And reviewing pre-visit and suspected diagnosis through that Medicare Advantage population, and then maybe your Medicare population. You can send a query to the provider for suspected diagnoses to get the diagnosis documented and coded to the highest specificity and acuity. The CDS to identify any other diagnoses to be captured for quality chart review and documentation, and then queries to capture RX HCCs. And RX HCCs, again, are the ones that are not really in those HCC categories. And then sometimes you'll see the patient is on medications, but there are no diagnoses to correlate with the medications. And so and it may not even be HCC, but you want to make sure that that chart is really, again, telling that patient story and making sure that we're providing all that we can for those patients. And then this is the visionary for that pre-workflow for HCC collaborate. So you can, again, you can prioritize by those RAF scores or those gaps in care, the next visit date, a specific location or physician. So just narrowing down what would be the most important and the most effective way in order to see those patients, like what would you want to do for that prioritization? And then you want to address the suspected conditions. If you're addressing those suspected ones, that can increase your RAF scores and then decrease those gaps in care, because the HCC Collaborate will show the ones that have already been documented COVID previously, but this will help capture more with suspected diagnosis. And then review the HCCs that are not captured on the claim with the current calendar year. Again, that's those suspected conditions. And then you would work through each of those diagnoses and review the associated documentation. And then if appropriate, you would do the provider notification. And then if you decided to do a post-visit workflow, you can validate if that condition was addressed and meet criteria was met by seeing if it was not documented or documented with or without the meet criteria. And that's kind of how we would do that reconciliation as well, just making sure that that was addressed. And then also, if a suspected condition was not valid, the auditor can mark that as an invalid diagnosis and remove it from the suspected conditions list, because that would not be an appropriate diagnosis for that patient. But if there's suspected conditions and we reviewed the documentation and that really was something that was a valid diagnosis, we have that and we could send those notifications to the provider. And then a visionary post-visit workflow for HCC Collaborate, create notes and flag the provider about a condition that was not addressed at a previous visit. So maybe it was a new HCC that was found, maybe that wasn't captured properly. And again, if maybe it didn't meet that meet criteria, or if it was unspecified codes, we want to make sure that they're documented to that highest specificity or acuity, and also to validate diagnoses if it needs that further validation. And then for return of investment, it can really be hard for the outpatient setting. And so because within the inpatient, you can see that right away within that impact review, and you can see, okay, this query generated this amount. But for the return on investment, you can monitor it and not really even just focus on the monetary value, but can also look at like your risk adjustment scores, okay, and seeing, hey, this is where we started, and this is how we impacted those risk adjustment factors. And because once those risk adjustment factors have increased, then of course you will have more monetary value with that. But it's also showing you that you have that higher patient acuity, and you utilizing these resources, and you want to make sure you're capturing that accurately. And then maybe taking advantage of those Medicare Advantage plan incentives. So making sure maybe you can look at, okay, this is what they are offering for incentives, and then we were able to answer some of these, and that's how we're able to show the worth of that program, by this is the incentive amount that we were able to capture through those. Maybe looking at the year-end reporting, comparing each year to the previous year, your quality reports, and maybe if your HCC capture rate. So those are just some things to do with that if you don't have like software in place. But if you have a software system that's in place, you can be able to see, okay, these were my risk adjustment. This is what it was prior to sending the providers those queries, and now this is what it's increased to. And then you can be able to see that right away a little bit more than waiting for those more manual processes. So that's just some examples of return on investment for the outpatient programs. And then for lessons learned, just making sure to have a clear goal for your outpatient CDI program with your senior leadership involvement, making sure you have measurable goals to be able to see your return on investment. But then, it's just really important to have the goals anyway to see what works best for your facility or for your organization. And then collaborate with all your other team members to maximize your efforts, because if you have an ACO program or your population health and other team members just working together, and that way you can address a lot of those same things, just working as a team. And establish a scope of practice and a mission for your program. CDI software, really does help because that manual process is very tedious. And then making sure to get your physicians on board, set some expectations, educate them on why it's important, and then having a physician champion to advocate for the program as well would be something that would help just to make sure it's more successful for your outpatient CDI. And that's all I have.